I request our beloved Chancellor, sir, and Dr. S. M. Balaji, sir, to
Yes, sir. Improve from time. Then you move forward. Get them. Come, come, come. Government dental.
from the organizing committee of Rome, we're very proud to have sir with us and our beloved Chancellor. And we'd like everyone to know that SMB sir has kindly sponsored these books for all our delegates. We thank our beloved Chancellor, sir, for gracing us with his presence. Thank you, sir.
Live Facebook live going. Start editing it. Okay, I'll take it. Thank you. Thank you. Thank you. Thank you, sir.
Sir, please, sir. Our next lecture is on the topic Pediatric Calvarial, Frontal and Orbital Remodeling by Professor Dr. S.M. Balaji, sir. Sir is an acclaimed oral and maxillofacial surgeon with over 28 years of experience, performing more than 20,000 surgeries, especially in the field of cleft lip, palate, and craniofacial surgeries. He is the editor-in-chief of the Annals of Maxillofacial Surgery, the executive editor of the Indian Journal of Dental Research, and has authored the country's bestseller textbook on the textbook of oral and maxillofacial surgery. So we've all grown up reading Sir's textbooks and are still reading it for our exams. He has also authored various international and national textbooks, publications in multiple journals of international repute. He is a member of the Indian Council of Medical Research, doing groundbreaking research in the field of reconstructive surgery. His work on bone morphogenetic proteins has won him the prestigious Brahmaya Sastri Award. To add to his accolades, he is also the recipient of Professor David Precious Award and the coveted Dr. Jinwala Rolling Trophy twice. We welcome you, sir.
Thank you for staying back, and I hope my lecture is useful to all of you. I took a long time to prepare based on your interest. First of all, I would like to thank Dr. Naveen and Dr. Emmanuel. Both of them were very instrumental in inviting me here. Also, I would like to thank our Chancellor for his time all the way here, and Dean Dr. Taman, also my brother and good friend, your previous dean, also I would like to Dr. Ravindra, and all the faculty. You must be wondering what way we are connected to pediatric, calvarial, frontal, and orbital. Being a maxillofacial surgeon or a craniofacial surgeon, how we are connected? It's only a neurosurgeon's field. Why we have to do all these type of surgery? So when you look at this child was referred in our WCF, World Craniofacial Foundation, established by late Professor Kenneth Salyer. Day before yesterday, I was in Dallas with them. He is no more now. We had the board meeting in Dallas, and I had another meeting in New Orleans. And I came only today morning because of the invitation by our friends. So when you look at this child, it's not only craniosynostosis. You can see the VP shunt. You know what is VP shunt? I think I will ask Naveen how he wants, and Emmanuel, how he wants the lecture. You can make it interactive.
Yeah.
Yeah.
That is the idea.
So that is better, because these kind of surgery, our cancer surgeons are here. When you take up any reconstruction of the maxilla or mandible or a oral cancer, it takes 8 to 10 hours when you take a fibula. And the patient comes after the age of 60. When you go through the records, medical record, his creatinine is high. Now the problem is you need a good medical ICU because he has somebody to look after his kidney post-operative. 10-hour surgery, hemodynamics, the kidney has takes the all load. Now you go through the report, his ECGs, there is some problem. You are going to remove the maxilla and do the neck dissection and do the pre-fibular flap. I'm sure you would have gone through all these lectures. Now, when the ECG changes, you need a good cardiology team. Not only that, it's a prolonged surgery, and age is high, and medical risk is there, and then definitely bilateral neck dissection, you go for tracheostomy. Post-operatively, your anesthesiologist will tell you, please, I don't want to remove the tube, you have to go for tracheostomy. And the patient is in the tracheostomy for 2 weeks, and somebody to maintain the lung. He should not go into bronchopneumonia. So you need a nephrologist, cardiologist, pulmonary, and B. So these kind of surgeries also takes when my mentor, Professor Kenneth Salyer, first in the world when he separated the conjoined twins, he took 48 hours surgery. Muhammad and Ahmad, they are the only first case living now. The head were joined, separated. They took 48 hours to do the surgery. That means 8 hours of anesthesia. So all these surgeries, they take a long time. So our pediatric anesthesiologist, I must thank my anesthesiologist for 25 years, Dr. Ramesh. He's one of the best in India. Also my neurosurgeon, Dr. Shankar Ganesh. Previously it was Dr. Suresh Babu. He's not operating now. He's mostly giving chances to his youngsters. So when you take up, that is the reason why I wrote this. A child requires the skull, total calvarial reconstruction. Then not only that, you have to bring the eyeballs together and the oblique facial club. Then you need to correct the maxilla, palate. Now you need an orthodontist, you need a pedodontist, you need a dentist, you need multi-specialty. That is why we are in need. Okay, before I show you and discuss about all the different types of craniosynostosis, I'm going to show all the classification because I'm going to show you all the types operated slowly one by one so that you understand every aspect of the surgery. And before going into that, we need to know a little bit of embryology because this is the KISS theory, that is Dasse and KISS. When I'm sure Dr. Ravindra will know, when we went for first year BDS, our madam, Mrs. Jaykumari, taught us anesthesia. He's laughing, look at him. He knows when both the processes don't fuse, you get cleft. That was the theory, his theory. I say yes. But what is this type of cleft? How do they form? Can I ask you this question to all of you? This is, if this theory is correct, how do the other clefts form? Nobody has an idea. I'm coming to that. Okay? So anatomy and embryology is different now. So we go into the mesenchymal penetration theory. Okay, when there is a failure of fusion, when there is the ectoderm doesn't break and the mesoderm doesn't fuse, that is this form. The theory is functional reassignment theory. That is the called. I'll get back to you. This is the neuromery theory. So when you look at any fetus, intrauterine life, you get the first. What forms first? The head. Then the trunk is small. So head forms means first the brain forms. First the brain. Then so the brain only sends signals through RNA. Okay, this is how. Why that child is, the face is formed like this. Do I look like my father? Do I look like whom you resemble in your family? Mother. See, that means somebody who's carrying all this, the brain. The brain dictates, brain sends signals to the periphery to create. So, that is how, that theory is not the only theory, the first his theory. When there is a deformity in the central nervous system, the CNS, central nervous system, is the master architect of your face. So I'm coming to that one by one. This diagram is very important. I know this looks different color coded, but I will make it very simple for you. The yellow color is the prosencephalon. What is prosencephalon? Yellow. And mesencephalon and rhombencephalon. Okay. Forebrain, midbrain, hindbrain. So the hindbrain is important for us. The rhombencephalon. You see that the pink color, that is the rhombencephalon, gives rise to the rhombomeres. Okay. And each color coding, you see that each one is separated by the Hox genes. So this diagram is another important diagram. When I told you, again you see the red color, the yellow, and the blue. The red is from the prosencephalon. That is, you can see the red and the yellow and the with darker yellow and the blue. So these are the rhombencephalon, the hindbrain, which gives rise to rhombomere. The rhombomere 1, 2, and 3 gives rise to, look at the diagram and tell me. Pharyngeal 1 gives rise to the facial bones. Which one? The bones, incus, malleus, and the Meckel's cartilage. What about the second arch? You see that? 4, 5, and 6. Okay, 5. And the next is thyroid cartilage. Okay? So this is how the rhombomeres form and the pharyngeal arches are formed. Now we go into the forehead and the orbit. So formation of the bone and the orbit. Orbit develops around the eyeball. So orbital walls are derived from the neural crest cells from the frontonasal process and the maxillary process. Flow and the lateral walls of the orbit are contributed by the maxillary process, and the lacrimal and the ethmoid bones are contributed by the frontonasal. You see there, the neural crest cells come from the hypothalamus and the cerebellum. And you look there very clearly how the cells migrate from the prosencephalon. Okay? Next. This is very important. This diagram will tell you very clearly. When you see this diagram, when you look at the intrauterine life, first, second, third week, the eye optic pit, the eye is in 180 degree. Okay? 180 degree. As the fetus develops, the third month, it becomes 105 degree. So the eye moves from here, from the back to forward. Okay. Now who tells this? One eye can be here, one eye can form forward. No. Who controls all this? Again, the neuro, the brain. The brain sends signals. Otherwise, I don't think I will look like my father. That's something else wrong will do. So, and as the eye moves forward, finally at the time of delivery, 71D. You can see that? Top. So, that is why. When it stops there, what causes? Hypotelorism. When it is moves too much forward, now you understand? Simple. Okay. Now we go to CBR and FOA. CBR is the cranial vault remodeling and FOA is frontal orbital advancement. Okay. Now refers to the reshaping of the entire cranial vault. CBR. And this is frontal orbital advancement. Next, we go into my topic of craniosynostosis. It's defined as premature fusion of one or more cranial sutures leading to an abnormal skull shape, preventing the normal growth of the brain and leading to complications. Okay, I'm going to go into the basics. You know all the sutures. Metropic suture, coronal suture, sagittal suture. One more. Good, very good. I'm happy. Okay. Now, when the child is born, you send the patient up, pediatrician keep checking. Whether when you suspect craniosynostosis, he keeps measuring the, circumference of the skull. So, cranium has 6 major sutures, 2 coronal, 2 lambdoid, a metropic and a sagittal suture. At the birth, these sutures remain open. In one place in the maxilla and mandible, we want the sutures to close. On the cranium, we don't want them to close. If they close, there will be compression. ICP increase, there will be a problem. Okay? So, the fusion of the suture is a gradual process and completed by 6 to 8 weeks. Okay? And it will be slow. Because we want the brain to grow. Brain doesn't grow all the time. It stops. Only the bone, then finally it gets fused. So, metropic suture 6 to 8 months. Sagittal is 22 years, coronal 24 years, lambdoid 26 years. Okay? So, you see what there, when you take a baby at the age of 6 months or 8 months, that's here you see the pulse. Okay? In a long surgery, sometimes the anesthesiologist, they keep their finger here. I have seen Dr. Ramesh, man, he keeps here. You know why? He check. Senior anesthetist will know the pulse one, and one is the temperature. The temperature also, if the child is going for hypothermia or hyperthermia. Okay. Okay. So these are the, about all the sutures which we have already discussed. I'm going to tell you when there is a future of the, the anterior horn, especially the metropic suture, you get trigonocephaly. What is that? Trigonocephaly. When there is a coronal suture, brachycephaly. When sagittal suture, scaphocephaly. Lambdoid, posterior brachycephaly. Okay? Now, these are the simple fusion and multiple. And let's go to the syndromic one. Okay? So, there's a theory on this, on the sutural growth and early fusion. Virchow, Moss, and McCarthy. Virchow says when there is a fusion of the suture, there is elongation of the skull. And Moss says there is there is a primary defect in the mesenchyme. And McCarthy also says there is a primary defect. I think the McCarthy is right. There is a defect in the base of the skull and in the blastema. So the fusion occurs early. Fusion occurs early. Okay. Next, classification of craniosynostosis. Primary and secondary, syndromic and non-syndromic. And non-syndromic is simple. When you see the child, they look normal, there will be complication associated with cyanosis. Whereas syndromic, there are other problems. I'm coming to that. Okay? This I already told you. Clinical manifestations, non-syndromic. So, these are the various genes involved. And sagittal cyanosis, scaphocephaly, or you can call it dolichocephaly. Coronal, anterior plaggy, and bilateral is brachycephaly. Lambdoid, posterior plaggy, and metropic diagnocephaly. Okay, scaphocephaly, you can see there. You understand this point? There is no suture there, it's not open. That means the sagittal suture is fused. So it's the skull is elongated. Okay, see here, elongated. This is how it is. So by surgery, you need to modify. This is a child I'm showing you where there is a fusion of sagittal suture. So because there is a suture and there is boat shape and there is compression. Okay, such a child is restless, there is increased ICP. So definitely this boy requires surgery. Okay, these are the various techniques where you need to, after opening the cranial dome, multiple bones, then barrel sleeve cuts and calvarium removed and modified. This is how, first when you do a surgery, with my neurosurgeon, we are very careful not to, because the baby is 6 months, 8 months old, there will be blood loss. And if there's a blood loss, first the baby, the positioning is important. I'll show you now. Then arterial line is important. Temperature monitoring is important. Multiple IV lines. Arterial line is very important because suddenly you open into the superior sagittal sinus, and if there's a bleeding, you should be able to control, pump blood quick. Pump. No drop by drop. You have to push. Otherwise, what will happen? The child will go for cardiac arrest. Okay? Right. So this is just to show you scaphocephaly operated post-surgical. I will show you the surgery of the different cases also. Okay, this is brachycephaly. That means coronal suture fused on one side. You can see that? So you understand now, you can visualize. You will never forget this. Sagittal suture not there, one side coronal. Okay? That's right. Okay, when these there will be total deformity of the skull. All right. And this is very important where you find, look at the skull. One orbit is normal, other orbit is lifted up, pushed back, and the deformity is called? Yes. You all know about it. Okay? Now look at the child who left on the left eye. So I will show you the surgery also. I'm coming to the next. Once we finish the classification, we will go further. This is pre-surgical and post-surgical skull. Okay, brachycephaly. What is brachycephaly? Look at the diagram and tell me. Bilateral coronal suture fuse. Okay, you can imagine now sagittal and unilateral and now bilateral. Okay, now you all know that. Look at the shape of the skull. You can see that. See now. Look at the shape of the skull. Because there is bilateral fusion, there's no growth. Sideways it grows. Expansion of the brain and the sideways. So this child, you can see that. Okay, right. So this is the line diagram to show how you advance it. Okay. Next is posterior brachycephaly. What is that? What is absent now? What is fused now? Unilaterally it is fused. Excellent. That is nice. Okay. That is the posterior. And this is a child with the Lambda-stenosis. Okay. This is trigonocephaly. What is it? Which suture is fused? Metropic. So you share very sharp. Okay. That's right. Okay. This is how it looks like. Okay. This is a boy from Chandigarh. I will show. Okay. That's how the brain also shapes like that. This is I will show you the surgery, how you can advance the orbit, how you can correct the orbit, how you can bring a normal forehead. Okay? This is how you should do the surgery. The orbital frontal bone is taken out. You can see it nicely. And these are resorbable plates to create a nice forehead. Okay? Right. So, this is deformation of brachycephaly. There is no fusion of the sutures, but it's totally deformed. Okay? That also requires some Calvarial reconstructions. Okay. Functional problems. What are the functional problems? ICP increase, limitation of brain growth. Very important is visual impairment and neuropsychiatric disorders. And extracranial sutures, frontal orbital rim recession, mid-face hyperplasia, and flare in the supraorbital rim, bulging of frontal nail, exorbitism, limb abnormalities. I'm going to show you all type of cases. Okay? Clinical manifestation. Syndromic, these are heterogeneous group of pathologic conditions. that involves premature fusion of single or multiple craniosuchers are associated with various congenital anomalies, and they are genetic etiology. Okay, which are the syndromes? I'm going to show this syndrome: Apert syndrome, Cruzan syndrome, fibers, and Carpenter syndrome. Okay, Apert syndrome. There's other associated deformities like syndactyly, okay, and other facial abnormalities. They bring the child to you, look at the shape of the head. Can you see this? The syndromic craniosynostosis is a multiple problem. So this cannot be operated only by the neurosurgeon. Definitely, they need the support of us. So that is why we come into the picture. Okay? Apert syndrome, another here. Okay? All that. Right. Okay. Cruzan's also. Cruzan's also, there's bicornal stenosis and there's copper beaten appearance is very important. I'll show you when I'm going to show you the surgery how when we open it, you see the skull inside part, it's totally different from the others. So in Cruzan, you get multiple suture fusion. Okay. Pfeiffer's also same. It looks like a little bit like Cruzan's mid-face protrusion. Definitely, it requires move for, after the craniosynostosis surgery, lymphoid advancement. Okay? Right. And Pfeiffer syndrome, this is the skull, we can see that. And what are the investigations you do? Okay? You need to, your pediatrician will do certain investigations. Then finally, your neurosurgeon will do, and your ophthalmologist. Fundoscopy is very important. Definitely, CC, you can find out the remote. And intracranial pressure, naturally, in multiple places, they put the catheter and measure the ICP. Okay? And that's more of the ICP measurement, and then we go into the surgery. Okay? Goals of the treatment: to correct the abnormal shape and prevent the ICP increase and expand the volume of the skull and protect the airway and cornea and allow the brain to expand and the shape of the skull to improve and reducing the exorbitism and correct the facial growth. Okay. How do you manage? Your mother is bringing the child to you. What do you do? First, you check pediatrician and neurosurgeon's opinion, craniectomy, they do a VP shunt. Okay? Most of the children will require tracheostomy and torsography. Then you can plan for the calvarial reconstruction. There is endoscopy. Endoscopy, now most of the people do not do this. It's not 100% successful. Mostly manual opening the craniotomy and total reconstruction. That is the best thing. Then later on, you can do a lymphoid advancement with distraction or facial bipartition. Okay? These things which I have already discussed, the goals of the treatment, sorry. Okay. Right. Choice of the procedure. Cranial vault remodeling, frontal orbital advancement, and other minimally invasive techniques are there. And this is on silk craniotomy. Some surgeons they prefer, but sometimes there is recurrence, they come back to you. And endoscopic also, there's recurrence, they come back to you. And some very conservative method of doing, helmet. There's also, this was also practiced before. They make a cut, they put the spring to expand, and monoblock advancement, where you make it and put the distractor. That is also possible. And frontal orbital advancement. Okay. And each surgery, I'm going to show you. This child you saw that. Okay. This is a scaphocephalic. First thing, positioning of the baby is important. Okay. 3D model study, then planning the. Okay. And you all know a bicoronal approach. Then using your ball or with the you can make a drill, then connect the drill with cranial dome, do a calvarial reconstruction, total calvarial reconstruction, and multiple cuts on the bone is very important. You see, multiple cuts, multiple holes, nothing will happen. There will be new bone formation, and you see, even immediate post-op, you can see the shape of the skull. Okay? And it is fine. And This is a before and after skull. You can see. You look at the before and after shape. Before and after, and that's how he looks now. See from here. Okay. I want you to see. This is how he was. Now look at his recent picture. Okay. He looks now. Okay. Scaphocephaly. Another child. Look at the skull. So you all know sagittal suture fusion. There is compression, expansion on the skull. So you need to do the total Calvarial. So this is the positioning the child. You can see how he is positioned and face down and biconal approach and craniotomies, and that is how he is post-operatively. And see now the shape of the skull. Can you see that? One side is tilted, it's very straight now. Okay? And placental unicorn stenosis. You can see the eye shape on one side, on the left side. So look at the skull here after the bicorner. On the look here one side. Okay. So placental unicorn stenosis. One side is not grown. Is the frontal orbital segment is taken in hand, and you can see me remodeling and see this. You can see the resorbable plate there. Okay, that's how she is. Another boy, same procedure, bicoronal, multiple cut, not to damage the dura or the superior sagittal sinus, and multiple resorbable plate. That's how she is. See the skull is very straight now. From this shape, you can see the normal shape of the eye, normal. Okay. Another unicornal stenosis, and you can see the depression of the skull. Okay, same procedure and total remodification. And look at that immediate post-op. Okay, and immediate post-op, just 1 week old, the sutures removed, and look at the shape of the skull. So that was at the time of surgery, at the time of suture removal. Suture removal also, babies, they don't allow you to do it with, they have to give anesthesia. That is why I was able to take the picture. Okay? And that's there. Look at it now. This is another one, unicornal. This, very interesting, somebody tried to do the surgery and I think something went wrong. So redoing is very difficult because they've already attempted, there will be multiple fusion and dura stuck to the skull. So when you try to elevate, you land into creating more bleeding and more CSF leak. So this is the girl, 7-year-old. The planning is important. Okay, look at that. Okay, so how we have planned it. Okay, craniotomy. Then one side of the, the skull is cut on the temporal bone, brought forward and bent and remodeled. I'm showing you. I will show you the picture. Okay, look here. This is the important picture. The other one. Can you see that? Because she's quite elderly, some 8 years old. I have put some rigid plate. Because when you make all the cuts, resorbable plate will stay. But resorbable plates, you have seen KLS Martin, now Johnson has come. You need to warm the plate. Resorbable plate, how they fix it? Not like the rigid titanium plate. You need to put it in warm water, then bend it, cut it with a scissor, then fix it. And then if it is on flat surface, it is okay. But if it's you want to advance it, you need to advance and put one plate on the zygoma. Then only the eye, the orbit will stay there. Or you will go back. You know why? Once you put the scalp back, because of the body temperature, the resorbable plate will bend. Okay? Right. You see that? So much is advanced and multiple resorbable plates. Okay, that's how it is. Okay? You see the difference? You see those two plates which I put it, you can see the rigid plates. And you can see, I'll show you the straight view. Look at the straight view now. How nicely you can see the symmetrical how nicely the orbit is formed, okay? That's right. Brachycephaly. This is a Cousins. Mother is also Cousins. Mother, I have done the Lipot 3. Okay? Now the son also the same problem, but craniosynostosis. So in Cousins, there's multiple sutures are fused. We don't know which are fused. Most probably sagittal, coronal, lambdoid. So you need to totally dismantle everything. Okay, then put back. Okay, with multiple resorbable plates. That's it. Because this child is quite close to me. I've already operated on the mother. You can see the mother is also Cousins. So he's wearing my specs. Okay. So some people, another child, brachycephaly. Okay, you can see the forehead, no? The brachycephaly, bilateral coronal sutures. So this child is from Hyderabad. He was not normal actually, highly restless, crying all the time. You will see after the surgery. This is the planning. See, I have marked to the pen how you make the bone cut on the frontozygomatic suture into the roof of the orbit, on the frontonasal suture, again roof frontal. Okay? That's how. And total reconstruction of the orbit, if you can see the resorbable plates. He's there. Now he's okay, he's cool. Okay? And again, Cousins, copper beaten skull. Look at the skull. All sutures are fused. So again, these also, you will require total, this is what I want to show you. When you do the craniotomy, look at the shape, you can see. You know how these are formed? You know? Yes, that's nice. Good. Well done. Okay? This is the child after surgery. This is a recent picture. The same child. Okay. Craniosynostosis, very interesting. Okay? This is again craniotomy, frontal orbital advancement, reshaping, total remodeling of the forehead. So, after the craniotomy, take it totally out, then remodel. Actually, what happened, this is all my earlier cases. The one which I show you later, I have modified my technique, so it's a better result. Okay, this you can see the resorbable plate here, and the midline I made a cut and shaped it, but still, the results can be better. So this is how he is. This is a Balaji boy. Wearing the development. Okay, before and after. Another girl, Craniosynostosis metropid. Okay, this is how once you take the frontal orbital trim, it will be like this. So you take it in the hand. Then here you can nicely see I have made 2 cuts. Can you see here? 2 cuts and resorbable plates. And the result is better. For good. Another metropixenosis, same procedure. Okay. Another metropixenosis. This is how it is. Okay. See here? This technique gives a nice forehead, nice orbit. New bone forms in between. When you put it back also, the new bone forms. Okay? Look at the skull now. Can you see that? Okay. That's how he is now. Totally changed. Another girl from Oman, same. See, she had ICP increase. So after the surgery, the girl was very happy. And total calvarial reconstruction, same procedure. And look at her now. How she was before. Okay? She's bright, looking bright. Okay. Now with Cousins. Okay. Now that ends our cases of craniosynostosis. Now why are we connected to this? Even after craniosynostosis, what happens? I'll just show you 3 cases. That will be end of my lecture. Okay? So this child already craniosynostosis correction done. Cousins. Then the whole family of Cousins. Brother Cousins, she Cousins, father Cousins. Mother is hiding the face. Okay. But they are very nice people. So I have done after the craniosynostosis, I did the distraction. So, look here. This is a very important slide to show you. My cut here is very important to do a Lipot 3. When you do a Lipot 3, you should not break the zygoma. If you break the zygoma, then you cannot fix the distractor. Because when you do a Lipot 3 surgery, when you shake the maxillary teeth, it should move. The whole piece should move. Suppose when you make the cut and try to break it, it's not breaking, they break the zygoma, then you cannot fix the distractor. Can you see both the distractor fixed? Okay? And you see the orbit? And it's only the optic nerve is connected. Okay, rest all, and you can, the NLD is at the bottom, nasolacrimal duct is at the bottom, okay? Then distraction. You see, from that situation, it is moved forward. That is how we are connected. That's why when I put the first picture, I told you, why it's only neurosurgery topic? No, it's, we are so much connected to this. This is an immediate post-op. This is how she is now. She's a big lady, a mother with 2 children now. But luckily, the children, they are not two sons. Okay. This is also another case I must tell you. See, nowadays the problem is all these children, they have tracheostomy. So when she was a child, you can see the tracheostomy, correct? So now she was referred at the age of 16. Problem is 16 years they have not removed the tracheostomy. Now everybody is scared to remove the tracheostomy. You remove the tracheostomy, the child will die. So, okay, she was operated in Lagos, their country. It failed. Then they took her to Cairo. Again, it failed. I'll show you. Okay. See, they already operated. Can you see that? When she came to me, they tried to break it and put the plates. They could not do a monoblock. Can you see that? Multiple plates there. So if you don't do a monoblock properly and don't put the distractor properly, it will not move. Okay. There will be more CSF leak only. So I had to, first thing I have to remove all the plates. Then do a Liford 3. Okay. That's how she is. And tracheostomy is already there. I'll tell you, very interesting. Dr. Ramesh is doing the bronchoscope. We have actually 7 types of bronchoscope. And he said, no chance of taking the tracheostomy tube. You do the Liford 3, Liford or monoblock. Now, the latest KLS Martinez, this is the distractor. Before, there used to be only one screw. Now, they give a mesh there. So that you can fix it nicely on the zygoma. Then when you start distracting it, the whole face moves forward nicely. Okay? So that is the child, girl. Look here. I could not remove all the plates, okay? And some are buried in the skull. So I did the, you can see the mid-face advancement. All right. That's how the occlusion. And then I told Dr. Ramesh to remove that. And Ramesh said, no, we need ENT people to come and see. Because when we tried to remove the tracheostomy, when he put the bronchoscope, above the tracheostomy, lot of growth. Entire superior portion was completely blocked. You remove the tracheostomy or you close it, what will happen? Total block. So we have to do another surgery, ablation. You know, go through that, and you can see Dr. Tirunakaras is doing the work, and he cleared the pathway. After that, I removed the tracheostomy. Then they went back home, okay, to Nigeria. That's how she is. She requests Leviticus, Okay. Now, facial bipartition. So I showed you Liford 3 of Cruzon. Another one, how we remove the tracheostomy. The last case to show you. Okay. This is a craniosynostosis, but there is a hyperthyroidism. You can see a brachycephaly, correct? Can you see the brachycephaly on one side? Right? Adult. But no complication. She is surviving well. So what I planned is, at the same time of doing a facial, the bipartition where you do hyperthyroidism correction, I decided to do the craniosynostosis correction. So first nasal external, do a bicornal flap, neurosurgeon, they come in the morning 6:30, they finish by 8:30, they go, they come back only at 5 o'clock to close. Till then, you have a job. Okay? So then you do after the craniotomy, they give mannitol, the brain shrinks. Then, when the brain shrinks, you can see the superior portion. You need to, this is the portion of that bone to be removed. Okay? It's that bando. So, yeah, bando is very important because if part of the cranial bone, if you don't keep it, imagine this bone is removed, you won't know the anterior posterior position of the, once this is removed, this is the guide for you. So when you remove this bone and translocate it, I'll show you the next slide. See, that part is removed. You can see the brain, the dura. Okay? Then bring it together with multiple plates. Okay? And that's the health minister came to look at it because some of the patients are referred by the government. So, okay, that's how she's now. Okay, this is the latest picture. I asked for ego. That's it. So now you know your importance. Now you want to know why you have to read all this. You must know about all the type of craniosynostosis. Okay, this is the last case, syndromic scaphocephaly. This baby was referred to me. Okay, look at it. You must be wondering what is our job with him. The child craniosynosis and cannot open the mouth. We have put the feeding gastrostomy. You can see that no, he is feeding through the tube. Now mouth is also not open. There is facial palsy, syndactyly. No, look at him. You know, poor people. Okay, look the CT. This is completely fused. So the problem is now, do craniosynosis separate the man. Vocal cord is opened up. Then he was able to put the tube. Okay. Then you see now, so everything performed. I asked the mother to send the pictures now. He's now like this. Look at him, huh? I'll show you. He's like this now. But no leg, no fingers. But you know, I'll tell you, these children will learn with what the little finger he has, he will. I'm going to show you a video. See, look at him. Okay? See? Very sad, huh? And they give a nice shoe, he'll start walking also. Then he'll start running and he'll go for the competition. Yeah, that is how, you know. These are my two girls. You know that there was a metropic stenosis. This is a plagicephaly. In the wards, immediately after the surgery, they are dancing and happy. So thank you very much for your. Thank you, Dr.
I think he needs much more standing ovation.
Thank you. We have some more discussion. Please go through my book. That is, a new book is coming. The second edition is coming. Yeah, the second edition will be soon, in another 2 months. So this, okay, now let me tell you something about the book. You go through each chapter, you will understand very well, you will be able to do the case. The book, if you read, 100% you will be able to do the surgery because I have given the line diagram. Did you go through the book? You will be able to do all the surgeries I have done there, and in the end I have given something. Have you got any chapter? Did you read? In the end I have given one. You have not yet given, okay. Surgeon's view I have given. Every surgery I have given, what problems I have undergone. What was the difficulty I have undergone? You don't do that mistake I have written there. So that is very important. I was also involved in cancer before, all from Kidwai. Then I changed my specialty from cancer to, because my teacher, my boss was a cancer surgeon, Professor B.C. Masan. Weekly 2 surgeries when I was a PG student. Weekly 2 hemimandibulectomy, heavy nose. Minimum 2. 2 mandibular resection, definitely. So we were more towards head and neck cancer. Then slowly I shifted my specialty from cancer to deformity, but still I do some lot of reconstructions. Thank you very much. God bless you all.
Thank you so much, sir, for that fantastic lecture. It was enlightening and inspiring, to say the least. I request our HOD and organizing chairman of the Rome 2024 to felicitate Dr. S. M. Balaji. for the pictures.
So hope you all understood about pain diagnosis. Now you all know all the different types. Very simple. Right? Thank you.
I request the organizing team of Rome 2024, our faculty, to come up on stage, please. So participants, this brings us to a close of Rome 2024.